Hi, this is Dr. Toby Moma, host of Health and Wellness with Dr. Toby, inviting you to watch our show this week with Dr. Troy and Farah Newman. Dr. Troy is a glaucoma specialist, board certified ophthalmologist, and his wife is a comprehensive ophthalmology specialist. And they're both working in Jackson, Mississippi, and they'll be sharing with you their life story. It includes a 2-year trip to Kenya as missionaries at Tinwek Hospital. They'll share with you how they've been able to raise 4 children, 3 boys and a girl. They've been married 13 years, and how they're pursuing their careers in their mid-40s in Jackson, Mississippi with a strong Christian foundation. They'll share with you their life stories, what they've gone through, how they've overcome them, and they'll give us a few snippets into what ophthalmology and what you need to be aware of concerning your eyes. You don't want to miss this show. Coming up with Dr. Troy and Farah Newman, we're going to be talking about your eyes. We're going to be sharing what God has done through them. You will be blessed. God bless you. Hi, this is Dr. Toby Moma welcoming you to this edition of Health and Wellness with Dr. Toby. God's will above all things in 3 John 2 is that you be in health and prosper as your soul prospers. And I want you to be in health. This show, we're going to be focusing on how you can stay healthy through the skills of Dr. Troy and Farah Newman, who are both ophthalmologists. But before we go into that, they're also medical missionaries. And for the last couple of years, 2 years to be exact, 2016, 2018, they served at Tenwick Hospital in Kenya under a group called World Gospel Mission. And they're going to tell us exactly the details of how you can pray for them, how you can support them, how you can write to them, how you can be a part of their community and know what they're doing all around the world. And I want to say that they're an excellent group. If you want to support them, they are people of integrity, and I can vouch for their loyalty and faithfulness to the call of God upon their life. So, Farah, you wanted to tell us exactly how people could reach you?
Sure. Yeah, so there's several different ways that you can reach out to us, and we would love for you to check all these out if you'd like to. One, through our agency, which is World Gospel Mission. There's a website, www.wgm.com, and then .org. Sorry, wgm.org. Sorry, /
we're going to put it on the
Troy
screen
Newman.
so you'll get it.
And we also have a blog that you're welcome to read and jump on with us. And we'd love to have you reading that with us and leaving comments for us. That encourages us so much. And that is www.troyandfarahnewman.blogspot.com. Also, if you ever wanted to send us any written letter correspondence, we would love that as well. We definitely take in every bit of encouragement the Lord sends us, and that is P.O. Box 320-545, Flowood, Mississippi 39232.
Awesome. And we're going to get all that on the screen. So, awesome couple on God's agenda. They need any kind of support, prayer, financial, writing, social. Just be a blessing to them. But today we're going to talk about ophthalmology. Dr. Troy, you did a fellowship in glaucoma.
Right.
So can you explain to my audience who don't know what glaucoma is, what is glaucoma? What should they look out for? What are the critical things that they should be careful about in terms of avoiding glaucoma? And is it really a big deal for those who,
Yeah, glaucoma is one of the leading causes of preventable blindness in the world. It's one of the second leading cause of blindness in the U.S. And so it's certainly a big deal, very serious. The glaucoma itself is a condition that causes damage to the optic nerve, and the optic nerve is required for vision. It's often associated with an elevated pressure inside the eye, not always, but most commonly there's an elevated pressure in the eye. So it's important. In terms of prevention, it's really the most important thing is early treatment, recognition and early treatment. And so an eye exam, Certainly, if you have any risk factors, which include family history, African American race, age over 40, you should be getting examinations of the eyes routinely, or at least to be looking for any early signs of glaucoma.
So we should screen for glaucoma.
Especially
In
with those
patients with
risk
family history. And
Certainly, people who have risk factors.
family history, African American above 40.
Right.
Okay.
And for anyone, just large screening efforts, just random in the population aren't very high yield. But for you as an individual, if you just go get your eyes checked by an ophthalmologist, they will be able to look at you and tell you whether there is any suspicion about glaucoma, whether you have it, whether it needs to be watched more closely.
What's the you said the treatment was some eye drops. So when do you do surgery for glaucoma? At what point do you go from eye drops to surgery?
It can be complicated, but generally speaking, our first lines of treatment are with eye drops.
Okay.
Because it's safe. There's low risk. Surgical intervention, there's always some risk involved in any kind of surgery. So we typically will try to treat glaucoma with eye drops initially. And then if we see that we're not controlling it well with eye drops, whether the pressure's not controlled or we see some progressive vision loss, and we've exhausted our efforts with eye drops, then we start to consider surgery as an option.
Do you think, what number should my patients get worried, not worried, but concerned? What number, intraocular pressure, just for those who don't know, what number should they start getting concerned about glaucoma when they talk to their ophthalmologist?
Okay. Yeah, that's a tricky question. The big picture is more important, the appearance and the health of the optic nerve. The normal pressure range we generally consider to be between 10 and 21. You may hear your ophthalmologist or optometrist say your pressure is 15 or something like that. That's in the normal range. Anything above the normal range, we start to get concerned. But there are people who have glaucoma with normal pressure. So that small subset of patients has to be watched for. And then some people who have a little bit of a higher pressure may not have signs of glaucoma. But above 20 is probably a good general rule of thumb for people to be aware of, but it doesn't tell the whole story.
So if my father or mother had glaucoma, at what age should I start asking my doctor to assess, risk stratify, assess me for glaucoma, my optometrist or my ophthalmologist? I mean, should I do it at 18, 20, 15?
Well, it may depend on if your parents had glaucoma, when they developed glaucoma.
Oh, okay.
If they had glaucoma in their 80s, then you're not likely to have signs of glaucoma when you're 18. But certainly depends somewhat on the aggression of the glaucoma. Do they really lose their vision? There's no time that's too early. Certainly never too early to be checked. But over age 35, 40, if you have a family history of glaucoma, certainly that's a good idea to be checked. It might not mean that you need to be checked every year, but at least depending on whether there's any suspicion, that's a good time to go in and have an initial check.
So Farah, tell us, you work in a ophthalmological service. What roles do you play in that medical ophthalmological service? I mean, what procedures do you do? What other areas of concentration do you focus on?
Sure. So, unlike Troy, he's a glaucoma specialist, meaning that he did a year of fellowship after our ophthalmology training. I'm a comprehensive ophthalmologist. So, in the realm of clinic, that looks like a really broad spectrum for me. As far as what patients are sitting in my chair that I'm taking care of can range from children that just need glasses to adults that just want new contacts, all the way from glaucoma patients that are manageable and don't need the extended care of Troy at that point, to a lot of diabetic eye exam care. As far as surgical procedures go, most of the bulk of surgery for comprehensive ophthalmologist for me is cataract surgery, and a few other topical skin kind of conjunctiva conditions and things like that. But
some people get confused with optician, optometrists, and ophthalmologists. Can you give us an example, a reason, can you explain the difference between all three?
It's primarily, it begins with the training. So An optician primarily is somebody who will be working in an optical shop, helping to either put together glasses, work with contact lens fittings. Optometrists, typically there's generally a 4-year or so undergraduate degree, and then 4 years optometry school, and then ophthalmologists, after your 4 years of college, there's 4 years of medical school. So you're a medical doctor, and then 4 years of residency training in ophthalmology. So you learn surgical training during residency. So it's just a longer period of training.
So the optician deals with only framing the lenses? Does he do anything other than... He doesn't do the frames at all?
They probably are putting together glasses in the shop. Also maybe working with patients on fitting, or even contact lens fitting. That's often what they'll be doing.
Wow. Okay. Now, you guys tend to do a lot of microsurgery. Is that normal, or is that exception, not the rule? Because I know you use the special lens to amplify what you see. So is that a normal thing for ophthalmologists?
Almost all of our surgery would be considered microsurgery, because we're using a microscope to be able to see the detail that's required. So there are some procedures that we may do that don't require a microscope, and certain eyelid procedures and things like that. But any surgery inside the eye or on the surface of the eye, we're using a microscope typically.
Now, you guys have this mobile lens. I mean, it's like you brought it with you once when I saw you. You had it on the top of your head. You can use it outside the clinic. What is that typically used for?
So maybe you're speaking like an indirect ophthalmoscope.
Right.
Basically, most primary care physicians are really used to the direct ophthalmoscope that you can hold in your hand, move really close to the patient, try to get, in their pupillary area and get a view of their optic nerve. And so an indirect ophthalmoscope is what you saw me wearing, where it has kind of like a head frame that sits over your head with the light and the lens, that you look through the lens. And it gives us a broader view into the eye. The direct ophthalmoscope that primary care would use is a very magnified but very limited view inside the eye. So much more difficult to get a complete picture and of what's going on back there. And so this broadens our view to where we can see into the back of the eye, which is where a lot of pathology happens, whether it's at the optic nerve or whether it's at the macula or whether it's at the level of the retina. Most systemic diseases affect the eye at that level.
Okay.
Yeah.
So that's why we do the dilation of the eyes. And
That's
then
right.
Fundoscopy is basically looking in the back
It's
of
looking
the
in
eye.
the back of the eye, because people don't realize that black circle that you have in the middle of your colored part of your eye, that's actually just a hole. That's why it looks like a black circle.
Okay.
And so our view into the back of the eye is through that circle. And so if we dilate that, then that gives us much more of a appropriate and adequate view.
What can you diagnose with just a fundoscopy? Because in my clinic, I can look at the eye technically, and I can see a few things, but I guess with a fundoscopy, there's more.
Yes.
Yeah.
So what exactly are we looking for in a fundoscopic exam when we dilate the eye?
Sure. We
Well,
can diagnose a lot.
We can see a lot. Certainly, we talked about glaucoma, so we look at the optic nerve, and we can see characteristics of characteristic damage to the optic nerve that goes along with glaucoma. And then there are other optic neuropathies that may show up. We see the retina, and we see all the blood vessels. So so many diseases affect the microvasculature, hypertension, diabetes, and so we see that vasculature right there. It's the only place really in the body where you can see those tiny vessels. So some of the same damage that may be occurring to the kidneys from hypertension or diabetes, we can't see it necessarily. You have to do lab and everything, but we can actually see those vessels, see the damage to the vessels in the retina. So we can see retinopathy from diabetes, often people that we see have already been diagnosed with diabetes, so we know that they have it, but we can determine the severity of it. But occasionally you'll see somebody who really didn't even know they had diabetes, and now we see the obvious signs in the retina, and then we know that we can refer them to their primary care people.
And then the uveitis is another uveitis is a
Yeah.
complication. Is it in the back of the eye, or where do you see that if I want to diagnose uveitis?
So uveitis is in the anterior chamber
Anterior
of the
chamber,
eye most of the
okay.
time, and we do have anterior uveitis and posterior uveitis, so nothing's totally straightforward. But as far as like diagnosis in a primary care clinic, you would be looking for uveitis in the front of the eye, which is in front of the iris, which is the colored part of the eye, which can be difficult to diagnose, honestly, without, ophthalmological equipment. If it's really bad uveitis, you can literally see like a white layer sitting at the bottom of the eye, which we call a hypopyon. If it's not quite that developed or that severe, a lot of times it's just little inflammatory cells floating in what we call aqueous, which is kind of like a liquid in that tiny little space, which really requires a slit lamp with magnification. But you can look for symptoms of that, which would be, especially in a patient that has a medical history of like autoimmune diseases, and then the symptoms of like a really red and inflamed eye, pain, the patient complaining of photophobia, extreme, sensitivity to light. Then, it's that certainly in a patient that has, underlying systemic disease. And if not, still worthy to let the ophthalmologist check it out, because sometimes we find those underlying systemic diseases that we didn't know about,
Right. Tell me about the kids. When you see the kids fire, how often should they come for an eye exam?
Sure. So I'm not a pediatric ophthalmologist, but I do enjoy seeing children in the eye clinic, and so thankfully I've gotten to see a lot of children in my past, and so as far as like the question of when should children have their first eye exam, or when should they get screened, well, that's a variable answer too, but definitely all kids should have some type of eye screening by the time that they're 5, meaning that a lot of times nowadays, which is a great thing, that American preschools and school systems will have, just an automatic eye screening for entry into school. And that's a great thing for America. A lot of times, I just had one this past week, a grown adult now, we cannot do anything about it, where the one eye was the eye that didn't see well, and it was never caught early on. And so that eye just basically, as an adult, doesn't see. And those situations, children won't complain because their other eye sees good. So all children, should have an early eye exam before age 5, so that if they do have a weak eye or a lazy eye, then we can implement treatment and try to get that child back to some, good vision in that eye. From there, as to when to see an ophthalmologist or have an eye exam, well, it depends on what we find. If there's, anything that worries us or anything suspicious, or, any family history or something like that. I do tell mamas all the time that, if your child is consistently complaining of something, whether it's eye pain or strain, or just consistently saying that they can't see, and you're not just really sure, what their motives are, or if that's all really, what it is, I'll always just err on the side of bringing them in to let us check. We can discern all that just through the eye exam as to what the child really needs.
So let me give you a few questions my patients always ask me. What does it mean when I see stars falling? I mean, have you heard that before? So what does that represent?
Well, there's a kind of a broad
Dark
category
than
of
stars.
floaters.
Floaters, right.
And so we get that a lot. The thing to be concerned about are new floaters. So in any patient who all of a sudden has seen a new shower of floaters, dark spots floating in one eye, shouldn't really be both, but one eye, all of a sudden they're seeing new spots, but they should get checked. If they're seeing flashes of light that are going off, especially in a dark room or a dimly lit area, all of a sudden they're seeing these really prominent flashes off to one side, then that should be evaluated.
What are we worried about?
We're worried in those cases about a retinal tear. So
Okay.
a tear that could lead to a detachment of the retina. So often people will have some little things floating in their vitreous and the jelly in the back of the eye. And they may see those from time to time depending on the background and the lighting. But if that's just something that they see from time to time and it's kind of there, it's not something to get excited about. But if there's a new onset of floaters and or flashes
How about halos? They said they see, halos, like some. Have you heard that word before?
Well,
My patients come in
is
with
it
all
just,
that.
just a round light?
Round, yeah, like the halos on the top of an angel's head, and they see that. Is that a ophthalmological sign or?
Things that people may see. Sometimes we describe halos as being a kind of a glow around a light. So if you're looking at a light at night and the whole thing just looks like there's a big halo around it, that may be a refractive error thing. Often either the eye is hyperopic or myopic. Usually myopes, people who are nearsighted, see more like a starburst coming from lights. But
Sometimes it can be an early sign of an early cataract.
Oh.
You
Yeah.
know, definitely
Yeah.
you get kind of a disruption of the normal light ray entry, and so any of that distortion as it hits that lens that now is getting a little bit of cataract can induce all kinds of visual symptoms, symptomatology from the patient. So it could be, depending on the age of the patient that's talking about the halo, it could
How
could
about
be.
a curtain? There's a curtain dropping.
Yeah, so
Well,
that needs to be seen.
that needs to, if there's truly a curtain,
Yeah.
and it doesn't go away. Some people, transient vision loss is something different, and so vision loss that kind of is there and now it's gone, or it happens to both eyes at the same time. Those are things that may be more related to like migraine, headaches, or things. But if there's true curtain over part of the vision in one eye, and it's not going away, then they need to be seen right away.
That's a retinal.
can
Another
be
thing
retinal
about
detachment,
halos.
that's right.
You mentioned halos. The one thing I wouldn't want to miss, although it's extremely uncommon, is that if they're seeing halos around lights and it's also associated with pain and or redness of the eye, then that could be a sign of like an acute glaucoma. So that would be something. I don't want to scare people and have everybody rushing in, but if it's associated with pain in the eye, then that needs to be checked out.
Well, give me an example. How do I differentiate hereditary from just genetic causes from environmental? So I have a 5-year-old and the young man is losing his vision. At what point do I rule out hereditary? As a doctor, I know there's one called hereditary optic dystrophy and all that.
Right.
How do I know it's not that? How do I do a gene test, or is there a better way of finding out? Or how do you differentiate genetic from other causes like environmental for the young, for the pediatric? I know you're not a pediatric ophthalmologist, but just thought maybe there was a scientific way of finding out the difference.
Well, there's there are a whole lot of congenital things that affect the eyes. They're genetic eye diseases, congenital disorders.
And they tend to happen at younger ages.
Usually,
right?
these things might present, and sometimes even not until the teens where you see the vision loss. Often there's some characteristic findings that we would see, and so anyone who's having true vision loss should be evaluated by an ophthalmologist. But the so really it would be based on the exam findings. There are certain
exam
characteristics,
findings, and then we
some
have
testing.
further
There's
testing
lots
that
of
we can
testing
do
be done.
there
Okay.
in the clinic that you wouldn't have access to as a primary care physician, and then certainly family history.
Right.
Yeah.
Is a huge one.
Big
For
player.
for you as to hereditary versus environmental.
Because why I said environmental was I know in Africa they have this trachoma,
Yeah.
Right.
which is due to the fly, I think,
Mhm.
that patches on the eye.
Yeah.
We don't have that problem in America.
No.
So, did you have any experience with that in Kenya?
A little bit.
Not a whole lot. Okay.
That there's certain endemic areas where trachoma is really
It's in
really
West
bad.
Africa a lot.
And in our area, it used to be worse, but it's been treated. There's some community. There's some really big treatments where they treat the entire community with azithromycin or erythromycin. Treat the entire community at once, and it sort of kind of wipes out all the infection in the area. And those campaigns have been really successful to reduce trachoma in certain areas, and we saw some trachoma where we were, but
Though
it wasn't-
overall for the
but
world,
in-
it is still
yeah, there's
definitely
it's still a big
a
problem.
huge
It used to
burden
be the
of
number
blindness.
one cause in Africa. I don't know
Right.
if it's still the number
Yeah,
one.
I still think cataracts, take the lead.
Take the lead.
And then here, diabetes, in the United States, diabetes
Number one.
takes the lead, for blindness.
Last word. What would you tell my young girls and young boys in high school, college, using contact lens? I mean, what are your warning signs about using contacts compared to using spectacles? What should they be aware of before they start using contacts on a regular basis?
Sure. So contact lens wearing and fittings and timing is very variable, and you'll hear different things from maybe different optometrists or ophthalmologists that you talk to. And so we'll all have our preferences. In general, here are some general things that I think can apply in any case. Timing of when to go into a contact lens, as far as speaking to a parent that's trying to decide. I really encourage that the child be old enough and have enough maturity to know, to be able to follow directions and to be very appropriate with their contact lens wear. I also recommend that the child be able to put the contact in and take it out by themselves. Even though you may put that in the morning before school, that child needs to be able to handle the situation on their own if something gets in it or is bothering the child. So that can vary in age, but I just think those are some basic criteria to be met. And then speaking to those young people who are in contacts or wearing contacts at this point, your hygiene and how you take care of keeping that lens clean and taking it out and following the rules is just so very important. No matter whether it's a daily lens or if it's a 30-day lens, or ophthalmologists will tell you, and thinking every one of us scenario would say, that lens needs to come out at night for so many reasons. One, that lens needs to clean overnight. Number two, your eye needs to breathe overnight. So your cornea needs to have access to that tear film and that oxygen. It just needs that rest time. I try to tell my young people that are in contacts, honestly ask yourself, do you want to be wearing contacts and doing well in them when you're 30? And so most of the time it's a yes. And so if we want that, then we want to do what's necessary when we're 12 and 13 and 15 years old to give us that best chance. Because we do have patients that have to come out because of inappropriate use and contact lens wear as a young person. So, definitely take those lenses out, clean them at night, discard them and replace them in the time frame that is recommended to you. That's right. Absolutely.
Well, we've had a great time with Dr. Troy and Farah Newman. This is Toby Moma saying Jesus is Lord. I'll see you next time. God bless you. Thank you guys. Awesome.